Good evening, and welcome to the Penn Transplant Institute's Liver Transplant Virtual CME series. I'm Margaret Lead, Senior Physician Liaison at the Penn Transplant Institute. Before we get started, I'll be quickly reviewing CME information and explaining the Q&A portion of the session. Tonight is the second event in our three-part series, and this evening we will be providing in-depth information about liver transplant for the treatment of liver cancer. Regarding CME credit, this evening's event will provide one AMA PRA Category 1 credit. After the session, you will receive an email from the Penn CME office with guidance on completing the evaluation and receiving credit. There will be time set aside at the end of the presentation for Q&A. At that time, you can unmute your mic and ask your question. If you have questions during the presentation, you can ask them in the chat, and our faculty will answer your question during the time set aside for Q&A after the presentation. The faculty member presenting this evening is Dr. Maarouf Hoteit. Dr. Apt was called to surgery and unfortunately will not be able to join us tonight. Dr. Hoteit is an associate professor of clinical medicine at the Hospital of the University of Pennsylvania, the director of the Liver Tumor Clinic, and the medical director of the Penn Liver Transplant Program. After completing a fellowship in digestive diseases at Emory University School of Medicine and a fellowship in transplant hepatology at the Mayo Clinic, in 2009, Dr. Hoteit became the director of the multidisciplinary Liver Tumor Clinic at the Hospital of the University of Pennsylvania. Dr. Hoteit is a member of several national and international professional organizations. His work has been published in the World Journal of Gastroenterology, the American Journal of Transplantation, Liver Transplantation, the Journal Hepatology, as well as many other significant publications. Welcome, Dr. Hoteit.
Thank you, Margaret. I will share my slides. All right, thank you all for joining us this evening for a conversation today about pushing the envelope for cancer cure, liver transplant for liver cancer. As Margaret indicated, Dr. Apt had to be called in for a liver transplant, so he will not be able to join us for his portion of the call, and I'll do my best to cover his part. So the key objectives today is to describe the indications for liver transplant for hepatocellular carcinoma and discuss how we push the envelope, how we downstage patients with larger HCC tumors exceeding standard criteria. And we will review liver transplant as a treatment modality for cholangiocarcinoma. But we'll start first with some general principles, a general concept. So if we have a situation where we have a malignant disease that's limited to the liver, and the traditional approach to treatment is a resection of the tumor. But if you have a situation where the tumor is not amenable to a curative resection or any alternative curative therapy, either because of the anatomic considerations, multifocality within the liver, or because of liver dysfunction that precludes safe hepatic resection, then liver transplantation could be utilized to basically replace the diseased liver that carries a tumor, or here maybe the liver that is not as diseased but is carrying multifocal tumors that are not resectable, with a healthy liver from a donor. So in essence, this is a treatment that amounts to a radical resection of malignant disease with an intention to cure. Obviously, it is not a simple treatment to use, and transplantation is a very special type of medical treatment because in addition to the complexities of the surgical aspects of the treatment and the medical aspects, long-term immunosuppression, etc., there is a limited resource to consider, that donor organs are insufficient to meet the needs of every single person that might benefit from transplantation. So in the allocation of a limited resource, we have to abide by certain key ethical principles. A, utility. So as you are allocating a limited resource to a population that is in need, you have to maximize the post-transplant, maximize the benefit to the population at large who needs those organs. So your utility here is measured in terms of post-transplant benefit. That is, you're transplanting someone, how much will they benefit from that transplant? Second, justice. Basically, that the organs are allocated in a fair manner. And this resulted in a principle where the sickest patient who is least likely to survive without transplant should get the next liver. So the concept of sickest first. And finally, a general ethical principle of respect for persons' autonomy, where promoting and respecting patients' informed decision is something that is obviously standard in medical care. But you could see how the two concepts of utility and justice could be potentially conflicting, where you would have to provide the organ to the next sickest person and you're looking at the benefit to that person, but you also want to make sure that as you're providing that organ, that that person will derive long-term benefit from transplantation. And I'll illustrate with an example here that may be a little bit extreme, but to illustrate the point. This is a patient who's a 55-year-old man with multifocal hepatic recurrence of a pancreatic cancer after having had a Whipple 1 year prior. He has no other site of disease on a CT PET, no biliary dilation, but he has severe ascites, gets 7 liters of paracentesis tapped. The cytology on the fluid is negative. The serum ascites albumin gradient is consistent with portal hypertension, as in here, liver dysfunction is driving the symptoms, not cancer in the peritoneal cavity. Bilirubin is 12, reflecting severe liver dysfunction, and albumin is 2.2. Will this patient improve over current status if he receives a liver transplant? I would say probably yes. I mean, he clearly is highly symptomatic from organ failure, and you can remove the cancer that's in the liver. But the issue is, will the survival after a potential transplant justify the utilization of an organ? Here's the main issue here. This is the question of utility. We know that recurrent pancreatic cancer after a Whipple carries a less than 5% 5-year survival. So this is why, unfortunately, a patient in this situation is not a candidate for liver transplant for treatment of liver cancer. And this is because this is what we expect generally when we do a liver transplant. This is the national data in terms of the 5-year probability of survival after liver transplantation, with various here indications for liver transplantation, but they all cluster around a 5-year survival just below 80% of late. So you could think that the organ for transplantation here that is utilized needs to have an expected outcome for the patient that is high enough, close enough to the average that it justifies the utilization of the organ for that purpose. And this is, again, all due, of course, to the fact that this is a scarce resource. So in terms of using liver transplant as treatment for cancer, there are certain general principles for optimizing outcome. One is patient selection. So you have to define the subgroup that actually derives substantial benefit from transplantation, again, to address that utility concern. It is important to keep in mind that this subgroup is not necessarily static. What you might start thinking is an appropriate subgroup to be treated with transplant. You might learn, as you understand cancer behavior better, how to refine that subgroup better. And also, cancer therapy is improving. So how the impact of additional cancer therapy besides the transplant on outcome needs to be considered. And this is an evolving concept because cancer therapy is changing. So the subgroup of patients that may benefit from transplant as a curative treatment for cancer in the liver is variable depending on these parameters that evolve with time. But two general concepts that I think are important to keep in mind is that in most cases, the approach to utilizing transplantation as cancer therapy involves controlling the tumor with some treatment prior to transplant. We call it neoadjuvant therapy, or therapy for cancer delivered before the definitive treatment, which in this case is a transplant. So this appears to be important in improving the outcome. And the other important concept is the flip side of that, is that Conversely, if somebody is having tumor progression immediately prior to transplant, even if you don't see the tumor outside of the liver at that time, this generally is associated with poor outcomes. So for cancer types that went through that process of selecting a subgroup that benefits from transplantation, there are 5 right now, and some of these indications are less controversial than others, I would say. So we will focus in this talk on primary liver cancer, and specifically the most common forms of primary liver cancer, which are hepatocellular carcinoma and cholangiocarcinoma. I will not mention the rare tumor of epithelioid hemangioendothelioma, which is also a primary liver tumor that could be treated with transplantation. And then there are subgroups of patients with neuroendocrine tumors and colorectal metastasis to the liver, where transplantation has been considered appropriate in some cases, although particularly for colorectal cancer metastasis, this is an evolving field and somewhat controversial. So we'll focus today for this talk on primary liver cancer, specifically HCC and cholangiocarcinoma. Of note, these 2 types of malignancies, primary liver cancer in the form of cancer derived from hepatocytes, HCC, or cancer derived from cholangiocytes, cholangiocarcinoma, are an increasing public health problem in the United States. This is a trend in annual incidence of cancer between 2013 and 2017 in the US. And both men and women, it is among the fastest increase in incidence of cancer, liver and bile duct. And overall, it features 6 in the numeric number of cancer deaths in the United States. So it's a significant public health problem. So I'll start with the first section of this talk, discussing liver transplant for hepatocellular carcinoma. So there are some challenges to consider in treating hepatocellular carcinoma. Hepatocellular carcinoma almost always occurs in a background of a cirrhotic liver and as a complication of cirrhosis. So you have to consider, as you're devising a treatment, the status of the liver, how dysfunctional is the liver in deciding what is the most appropriate treatment. The other challenge is that you have a tendency for hepatocellular carcinoma to undergo early intrahepatic spread, even when it's a relatively small tumor. It undergoes hematogenous spread and driven by neoangiogenesis, new vessels feeding tumors, even when they are as small as 1 centimeter in size. This is why multifocality within the liver is common in hepatocellular carcinoma, and resection with a curative intent, as in you're seeing a single lesion and undergoing a resection, has a high rate of recurrence, up to 50%. And that is because you often have occult multifocal disease, even as it appears that the tumor is small in size. So what liver transplantation offers as an advantage is that you can now essentially resect HCC even with impaired liver function, because with transplantation you're not so concerned about how dysfunctional the liver is, because you're replacing the liver, replacing it with a liver from a donor. And then there is the oncological benefit of a radical resection. That is, you're removing the entire liver. So this is as extensive a resection as you can achieve from an oncological perspective of HCC. So you have huge, wide surgical margins. We discussed how HCC can have occult spread within the liver, and you'd be removing the entire liver, including these areas of undetected foci of tumor. And then you replace the cirrhotic liver with a normal liver, thereby restoring liver function. And also taking away the risk factor for further development of HCC down the line. This is why liver transplantation is essentially an attractive treatment for hepatocellular carcinoma. But when people used liver transplantation indiscriminately to treat hepatocellular carcinoma that is, 1, not amenable to resection, and 2 limited to the liver, the outcomes were very poor. This is an example from a paper from patients mostly from the 80s, where the survival after transplantation for hepatocellular carcinoma was horrible. Here, almost no one survived to 36 months to 3 years. That is because of the fact that many of these patients that underwent transplantation had very large, bulky tumors, and even though we cannot see any tumor outside of the liver, it probably is a stage where there is already micrometastasis and the disease was already incurable. And so that was the problem with early utilization of liver transplantation and hepatocellular carcinoma until the development of Milan criteria. So investigators from Milan, Italy, developed these criteria out of their observation that if you limit the size of the tumor that you do a liver transplant for, then the outcome is actually not bad. So the limitation in tumor size here that is defined by the Milan criteria, that subsequently based on validation in multiple other centers, appears to be the gold standard for liver transplant for liver cancer, which is keeping the size of a single lesion less than 5 centimeters, or allowing up to 3 lesions in the liver. But then if you have more than 1 lesion, the largest needs to be less than 3. And obviously no extrahepatic disease and no vascular invasion. The data from the original study from the New England Journal of Medicine paper from the 1990s is that the 5-year survival is 75% and the recurrence rate is 17%. So this is the first description of a patient selection that allowed transplant to be used successfully. And the key here is that this 5-year survival of 75% after transplant for hepatocellular carcinoma that the Milan group described is equal to the outcome of transplant without cancer. And basically became obvious that this is an appropriate treatment for this patient population. So what we have right now in the United States, how to actually get a patient with hepatocellular carcinoma within these criteria, a liver transplant, is that the patient gets evaluated to make sure they're an appropriate candidate for transplant. They get on the waiting list when that happens. They have to have chest imaging to make sure that they have no metastatic disease. And then they wait on the list for a minimum of 6 months, unless their liver dysfunction is severe enough to be transplanted for a different reason, which is liver dysfunction. They don't get priority for transplantation until they've waited for 6 months on the waiting list. And then they get a number of priority points determined by the regional median MELD transplant. And then they keep those priority points every 3 months as long as the tumor on serial imaging remains within criteria, and eventually receive a deceased donor transplant after waiting long enough. Typically, that wait is a year to a year and a half on the waiting list in our area. And because of the prolonged waiting, obviously, essentially all patients receive neoadjuvant therapy, most commonly chemoembolization, but increasingly radioembolization or external radiation therapy. The alternative to shorten the waiting time is to have a living donor liver transplant. In most cases, we still use neoadjuvant therapy prior to living donor liver transplant, but it significantly shortens the waiting time, obviously. And so when the standard criteria for transplant for hepatocellular carcinoma were developed, this is basically the demarcation line between curable hepatocellular carcinoma and incurable hepatocellular carcinoma. This is a staging system called the BCLC staging system that is commonly in use for hepatocellular carcinoma. And basically, stage 0 is a very small tumor. Stage A could undergo resection or transplantation. And stage A is basically essentially equivalent to the Milan criteria. But then you're left with additional patients that have tumor it appears to be localized to the liver, and exceeding the standard Milan criteria, we're saying the tumor is actually incurable because of tumor size and number. And this is about 20% of all patients with HCC, so it's not a small number. So efforts have been done to push that envelope in the direction of really understanding among the patients with larger disease than determined by the Milan group who would benefit from transplantation. And some of the early efforts in that direction showed that if you look at tumor size, and in this case, it's measured as the number of tumors plus the diameter of the larger tumor as one measure of how much tumor you have in the liver, and the alpha-fetoprotein, which is a marker of tumor activity or how active or aggressive the tumor is. It's actually a continuum that maybe it does not really make a lot of sense to have a sharp demarcation line at the Milan criteria to say everybody beyond that point cannot be cured, because the risk of recurrence after transplantation that you see here on the diagram, and actually in this case it's survival, not recurrence, the survival after transplantation is a continuum. As you have larger tumors, survival is worse. As the AFP is higher, the survival is worse, but it's not like you have one demarcation line at the Milan criteria where you have everybody after that does poorly. And the key to advancing transplantation for cure of hepatocellular carcinoma is understanding the role of neoadjuvant therapy. In the United States, almost everybody receives neoadjuvant therapy, which is either chemoembolization, radioembolization, or increasingly radiation therapy, to maintain the tumor within criteria on the waiting list. It's been difficult to show in different studies what is the impact of this therapy on keeping the patient on the waiting list, because almost everybody does it. And it's very difficult to show also the impact of this therapy on survival afterwards, because it is a common sense that because the waiting time is long, you have to do something else in the meantime. And so because such a large portion of the population gets it, it's difficult to demonstrate this outside of a randomized controlled trial, which has never been done and will likely never be done, because people consider this at this stage the standard of care. But what is important to note is what happens to the tumor when you deliver neoadjuvant therapy matters a lot in terms of outcome. So in this example, researchers have shown that patients who respond to chemoembolization, here in the dotted line, have a low recurrence rate after transplantation of their HCC, versus patients who don't respond have a much higher recurrence rate. So besides tumor size and tumor number, the next step is to incorporate response to therapy while you're waiting and selecting the patients for transplantation. And this is the concept of downstaging. So this was initially developed at UCSF, where the observation is that some patients with larger tumors, up to 5 lesions, and have, as long as the sum of the tumor diameters remains below 8 centimeters, still do well after transplantation. And so the concept here is that you would select patients who meet this threshold of tumor size and number that is now larger than the standard Milan, that you would deliver therapy that would then cause the tumor to be reduced in size until it meets the size cap of Milan. And then you observe the tumor for 3 months to make sure there isn't significant progression of therapy, and you would do a transplant afterwards. So that concept was developed at UCSF initially, and they've shown in that original study that this group that is downstaged does, in terms of survival probability, the same as the group within Milan. Here, T2 refers to the tumor size within Milan criteria. And so T2 and downstage, same outcome at 5 years. So this was also actually shown in a multi-center study, including patients from other centers, 209 patients. who meet these criteria, interestingly, the majority of cases, 80% of the time, with 83% of the time, with neoadjuvant therapy, you can actually downstage these patients. Of course, some patients will progress after that and not be able to get to transplant. But among the patients in this cohort that got to transplant, the recurrence rate was very low. Again, confirming what was seen in one center and multiple centers. And as a result of that, UNOS now allows exception points to patients within these downstaging criteria. So up to 5 tumors, as long as they're not large and the sum of the diameters is less than 8 centimeters. But is there a need ultimately to put a limit on tumor size and number at all? This is a study that was designed to look at that question. And so in this second multi-center study that we were part of here at Penn, we had 82 patients who had tumors that were larger even than the downstaging criteria, as long as they had no metastasis and no vascular invasion. And we compared them to 230 patients that meet the downstaging criteria. And in all cases, there was neoadjuvant therapy delivered to attempt to shrink the tumor, downstage it to within Milan, and then confirm stability prior to transplantation. This was presented in the American Transplant Congress meeting last year and is currently undergoing peer review, basically showing that the downstaging criteria, where you have a cap on tumor size, patients can achieve actual downstaging in a higher proportion, 83%, versus patients with bulkier tumor, you don't achieve that downstaging at the same rate. But if you are able to get them to transplant, their outcomes don't seem to be different, even though the numbers here obviously are relatively small. But again, showing that perhaps the issue is not so much tumor size and number, but rather tumor behavior and how tumor responds to therapy while you are observing it prior to transplantation. This is an example of a patient that actually was in that study from our center. This patient in 2016 presented with 4 masses in the liver that you can see here. There's 2 very large masses, 8.4, 9.6, had a 3.2 and 1.6 centimeter tumor in addition, smaller lesions. The AFP was 50, so not very elevated at baseline. He underwent several therapies between 2016 and now, including radioembolization twice, chemoembolization once, radiation once. And because of long-term stability, we thought, and he had no residual tumor, we thought he would be a reasonable candidate for transplantation. He did undergo transplantation this year. On explant, what came out when we looked at the liver was a much smaller tumor that is residual compared to what he had before, 2.5, 1.8, 0.4. So essentially the explant is within the Milan criteria, though we saw a small amount of microvascular invasion within the tumor, which we see sometimes. We know at 9 months so far he hasn't had a recurrence. So again, this is an example probably among the larger tumors that we've ever transplanted at Penn. But show that if the tumor response is favorable, you can get a patient through transplant. And this explant pathology suggests that the likelihood of recurrence is not very high. And so far, we haven't seen that. So what about pushing the envelope further? Vascular invasion. These tumors invading vessels within the liver, particularly invading the portal vein, are thought to be traditionally an absolute contraindication to transplant. The idea is that the tumor has gotten to the bloodstream, and so the likelihood of extrahepatic disease is incredibly high. There was, however, an international case series of 30 patients with tumor macrovascular invasion who responded to therapy, had a complete tumor response on treatment. And then the tumor invasion went away, And after some period of observation, they had no cancer recurrence and then received a transplant. And you could see in this group that while the recurrence rate is higher than what you expect in patients without vascular invasion, up to 40% in this group, their survival at 5 years here is 70% or so. So this puts them in the same ballpark as the Milan criteria, even though here you have to take this with caution because these are essentially case series. These are not, this is not a systematic application of treatment. This is more a proof of concept that with these, so to speak, cherry-picked cases, you can sometimes achieve cure with vascular invasion using transplantation. So this is an example of a patient at our center where we used the strategy. This patient had a 3.5 centimeter HCC with invasion of a branch of the portal vein. Here's the tumor, and it's a little bit subtle, but the portal vein here is invaded with the tumor. And so underwent Y90 once in 2018, TACE once in 2021. His tumor was completely necrotic, had no, based on imaging, had no residual vascular invasion, received a transplant, had no residual viable tumor and no recurrence at 1 year. So we think this patient's likely to do extremely well at this stage because he had no residual viable tumor, no recurrence at 1 year. But again, it's a proof of concept that in vascular invasion can, in some circumstances, be treated effectively with transplantation. I want to show this case also of ours where we attempted a transplant for a patient with vascular invasion and the outcome is different. So I think it's important to keep in mind this group is certainly at higher risk of having complications. But this is a patient that had initially 2 centimeters in size, both of them within Milan, treated with TACE and had a good tumor response, was supposed to get a liver transplant, but then had a progression on the waiting list with a 2.9 centimeter caudate mass that was invading the right portal vein and likely the caudate vein into the IVC. There was a clot that was extending from the caudate into a venule that reached the IVC. So clearly when we saw this, the patient was removed from the waiting list initially. We didn't think that it was possible to get him through transplant, but he went radiotherapy in 2016 and 2 further treatments, microwave ablation for small recurrences in 2017 and 2020. And in that context, with extended duration of stable disease, that we thought that we could offer him a transplant, and we did. It appeared on the explant that he had no residual vascular invasion, had a 1.5 centimeter residual tumor in the caudate, but about 6 months he had recurrence in a chest lymph node and a lung nodule. He got radiotherapy for that, and he's doing well at this time. His AFP had risen up to a couple hundreds and is back down after radiotherapy, but clearly this is not the outcome that we would like to see. And again, I think we still probably do not understand very well or don't have the therapies that allow us to properly select patients with vascular invasion for transplantation, with few exceptions. So this is an example of trying to systematically offer transplant to patients with vascular invasion. This is a study from Italy. It's a small study of only 17 patients with HCC and portal vein thrombus. And they only allowed branch portal vein, not main portal vein thrombosis, treated with radioembolization, and they offered liver transplant if there is a sustained response by 6 months. You can see that out of the 17 patients they tried this in, only 6 had a successful response that is sustained at 6 months. 1 of them subsequently had progression and couldn't get to transplant. 5 of them got transplanted, and 3 out of 5 recurred. So I think the issue is, of course, this is a difficult group of patients to treat. Select patients can be cured, but we still don't have a very good way to do that selection. But be it as it may, from the original selection criteria for curable HCC, sort of the curable, incurable envelope is being pushed in the direction of some tumors exceeding the initial size criteria if they respond well to therapy. And this is now hypothetical, maybe some patients with vascular invasion, but we still have to hone down a better way to select these patients who are going to benefit from transplant. So future directions in pushing the envelope for cure of HCC. Clearly, our current understanding of the risk stratification is based on tumor size and tumor number and response to neoadjuvant therapy. But this is only a superficial look at inherent tumor behavior, tumor aggressiveness, and the likelihood of cure with transplantation. There's active research in HCC biomarkers that look at tumor protein expression, cell-free DNA technology, tumor RNA, etc. And the hope is that this would yield a better understanding of tumor biology. That is, you can send a test that will tell you that this tumor is likely to do well with transplantation, unlikely to recur versus not. And I think that is what we hope the future will be in terms of being able to appropriately select patients for transplantation. And of course, evolution of systemic therapy for HCC holds promise. There is, in the past few years, increasingly effective therapy for HCC. Clearly, the patient, the way I think about this is that the patient with macrovascular invasion probably needs systemic therapy prior to considering transplantation as well. And this hasn't been tested systematically. I will move on to liver transplant for cholangiocarcinoma. This is a segment that Dr. Abt was going to give, and unfortunately, or fortunately for the patient, he's in the operating room performing a liver transplant, so he couldn't join us. So I will do my best to go over his segment. So cholangiocarcinoma is a rare cancer in the United States. We see about 3,000 cases a year. It's much more common in Southeast Asia. And the problem with cholangiocarcinoma is that the majority of cases are diagnosed late at an unresectable stage, and the median survival of cholangiocarcinoma in general is 6 months. So it's a bad cancer to have. Important in the discussion of cholangiocarcinoma is considering the classification, because these are essentially distinct tumors with distinct risk factors. It's important to clarify here the terminology. Extrahepatic cholangiocarcinoma includes tumors arising from the extrahepatic bile duct, either below the cystic duct insertion. This is called distal cholangiocarcinoma, distal extrahepatic cholangiocarcinoma, or within the above the cystic duct insertion and up to the first order bile duct branching, which is perihilar cholangiocarcinoma, and finally above that point where you have intrahepatic cholangiocarcinoma. So perihilar is the most common form, accounting for over half the cases, and intrahepatic and distal are the less common versions of cholangio. Important to keep in mind that I think these diseases, even though they're rare and subclassification is difficult when you're having a rare tumor, and understanding the subcategories is difficult in that context because of the fact that it's so uncommon. It's important to make that distinction. They're different, the risk factors are different. So extrahepatic cholangiocarcinoma and intrahepatic both are likely to be sporadic. Extrahepatic risk factors include PSC, that accounts about or primary sclerosing cholangitis, that accounts about 30% of United States cases, choledochal cysts, and versus the intrahepatic patients, where the risk factors are essentially chronic liver disease. So the way I think of intrahepatic cholangiocarcinoma is that the main risk factor is the same risk factors as hepatocellular carcinoma. Hepatitis C, hepatitis B, whatever leads to cirrhosis. So it's essentially a complication of cirrhosis versus extrahepatic that tends to be primary bile duct disease. So the typical presentation for extrahepatic is obstructive jaundice, because the tumor typically obstructs the flow of bile. So the patient is jaundiced as a result of the mass effect of the tumor, versus intrahepatic, where patients present with a liver mass, with a large liver mass. The typical presentation is not with obstructive jaundice, although obviously any tumor could obstruct the biliary tree, even if it's intrahepatic, it could push in that direction. But generally, the presentation is a mass lesion of the liver, versus extrahepatic is obstructive jaundice. And the other interesting thing is that in the United States, the incidence of intrahepatic is increasing, which I would say parallels the incidence increase in hepatocellular carcinoma because of the burden of chronic liver disease related to hepatitis C, versus extrahepatic, where the incidence is decreasing. So essentially important distinction to make. This is why we will split this talk into transplant for the perihilar cholangiocarcinoma and the transplant for intrahepatic cholangiocarcinoma, which are different diseases and are approached differently. This is the bismuth classification for hilar cholangiocarcinoma. I will not go into the details of that, other than saying that bismuth type 1 and 2 typically get resection, and in some cases will need a hepatic lobectomy. Bismuth type 3A and 3B will need a hepatic lobectomy because the tumor extends up into the bile duct, draining one lobe or the other. And the bismuth type 4 is where there is no way to remove the tumor, even while resecting the portion of the liver, and this is considered unresectable. There are other reasons why cholangiocarcinomas might be unresectable, which is encasement of major vessels in one lobe and atrophy of the other. So you'd have to basically be able to preserve at least one liver lobe that is healthy enough to sustain the patient so that the tumor is resectable. And if you can't achieve that surgically, then the tumor is unresectable. The other reason is liver dysfunction, particularly in PSC, because as we discussed, perihilar cholangiocarcinoma typically occurs or does not have necessarily an associated chronic liver disease, except in PSC, where you have consistently a liver disease to consider how severe is the intrahepatic PSC disease. And of course, metastatic disease, distant lymph nodes, invasion of adjacent organs is a reason for cholangiocarcinoma to be unresectable. This is a description of the surgical outcomes for resectable cholangiocarcinoma. And this shows that basically between the 70s up to the 2000s and the decade that follows that, there is improvement in surgical technique, perhaps improvement in patient selection as well, that resulted in the survival after resection of cholangiocarcinoma to be improved. But these numbers are also not great. So you look at the 5-year outcome of patients with resectable cholangiocarcinoma, even in the new era, it's 38%. So the 5-year survival, essentially indicating the frequency at which these tumors present late, and even with an intent to cure resection, the outcome is not good. And so there were attempts early on to offer transplantation to some of these patients as a more radical operation that offers a more extensive resection. Importantly, because many of the cholangiocarcinomas after resection recur locally. Some recur with metastatic disease, but local recurrence is very common. So the idea is, can you do a more extensive surgery, liver transplantation, and treat cholangiocarcinoma that way? And the problem, again, similar to the early data for HCC that we discussed, the outcome is poor. And the 5-year survival is clearly below 40%, even with transplantation, for patients with hilar cholangiocarcinoma. So again, we're going through the same exercise, if you will, like we did with hepatocellular carcinoma. the two key elements in improving the outcomes is one, patient selection. You have to understand which patients actually not applying this transplantation indiscriminately. Rather, select the patients that are most likely to benefit from this treatment and deliver some type of therapy that allows you to control the tumor while the patient is waiting for transplantation. And so this is the result of transplantation for hilar cholangiocarcinoma from a United States multi-center study published in Gastroenterology now about a decade ago, and showing that using a protocol by which you select the patients very carefully and you apply neoadjuvant therapy, you're actually able to achieve a survival after treatment of cholangiocarcinoma that is unachievable with other treatments. 65% 5-year survival. Again, if you compare it to the survival of liver transplantation in general, it is certainly a step below, but it's not so far that it's not an acceptable treatment for this subgroup of patients. So we'll go next over that selection process and therapy that allowed us to improve our ability to use liver transplantation to cure hilar cholangiocarcinoma. So the key items here is establishing the diagnosis, careful preoperative staging, obviously like everybody else, careful liver transplant evaluation, neoadjuvant therapy, and one additional step that we don't use in hepatocellular carcinoma is operative staging prior to transplantation. So diagnosis can be a challenge. Cholangiocarcinoma is difficult to diagnose, particularly perihilar cholangiocarcinoma, because our ability to detect the tumor typically using samples obtained at ERCP at the time of biliary obstruction is poor. So the sensitivity of regular cytology to detect adenocarcinoma in the hilar area, hilar cholangiocarcinoma, is about 30%. So in essence, your patient with cholangiocarcinoma that gets a negative brushing cytology not showing cancer, it's very difficult to rule out cancer on that basis because the sensitivity is so poor. We use advanced cytological techniques to try and improve that sensitivity. Fluorescence in situ hybridization here detects chromosomal abnormalities in the cells that may indicate malignant disease, and the sensitivity is variable but still not high enough to be able to confidently exclude the possibility of cholangiocarcinoma in somebody with a biliary stricture. We have advanced endoscopic techniques such as cholangioscopy, which also improve our ability to make a diagnosis, but also remains a significant challenge where the sensitivity is not high. So this is why the criteria for diagnosing cholangiocarcinoma in this context do not rely exclusively on cytopathology being positive. Because the sensitivity is so poor, we'd have to use other parameters that make the probability or likelihood of cholangiocarcinoma so high that we would consider transplantation. So these criteria are either a positive cytology, which clearly would nail down the diagnosis, but additional items to consider is having a malignant appearing stricture, as in a stricture that is tight, typically doesn't resolve with balloon dilation. You'd end up having to put a stent. Presence of an elevated CA19-9 in the context of a malignant appearing stricture. And I would say the CA19-9 needs to remain elevated after relief of the biliary obstruction and in the absence of cholangitis, or fish being positive, polysemia on fish. Despite the challenge in making the diagnosis, one thing we say, if we are considering transplant as a treatment for hilar cholangiocarcinoma, that we would not recommend doing either a percutaneous percutaneous biopsy of the tumor, if there's a tumor mass, or an endoscopic ultrasound-based biopsy of the tumor, or even open surgical biopsy or attempt at surgical resection, because these maneuvers where you violate the tumor and basically expose tumor cells to the peritoneum have been associated with a high rate of recurrence locally after transplantation. So this is considered a contraindication to considering the transplant protocol if the biopsy was obtained by those means. And so that is really a diagnostic challenge and something to keep in mind. If the likelihood of cholangiocarcinoma is high enough, then we would then we would utilize transplantation as an acceptable treatment modality without having to undergo procedures that increase the risk of recurrence subsequent to transplantation. And so this is the recommended workup for diagnosis and staging, CA19-9, ERCP with brushing. We do recommend performing an endoscopic ultrasound for sampling of the regional nodes, but the important thing to note is that we do not recommend sampling the tumor itself. In essence, if you sample a lymph node and it's positive, the stage of the disease is already beyond the resectable stage, and generally these patients are not a candidate for transplantation because their recurrence rate is high. So we do want to sample the nodes to make sure we're selecting the patients appropriately, but we do not want to sample the primary tumor with EUS, which can induce upstaging of the patient as a result of the biopsy and tumor spread. MRI, MRCP, CT scan of the chest, bone scan, and PET scan optional, basically making sure that there's no extrahepatic disease. After the patient is evaluated for transplant, thought to be as a good candidate for transplantation, and had this extensive staging process, they undergo chemoradiation with external beam radiotherapy plus 5-FU, and then they receive capecitabine oral therapy 2 out of 3 weeks. I'd say in our center more recently, we've introduced the concept that we can treat some of these patients actually with systemic therapy ahead of chemoradiation, then getting to transplant. So there's a select group of patients where we offer this to as well. Operative staging. So after the patient undergoes neoadjuvant therapy, they're on the waiting list. Before performing a transplant, we perform a lymph node and an exploratory laparotomy with basically looking for any evidence of peritoneal implants from cholangiocarcinoma or positive lymph nodes. So there's a lymph node dissection and examination of the peritoneum to exclude local spread outside of the liver. Our surgeons here do it with a minimally invasive small incision. Typically, this is important to do because even with the best efforts, in about a quarter of the cases, there's already spread outside of the liver. So it's important to do this to make sure we don't do a liver transplant in somebody who already has extrahepatic disease. We prefer living donors for this maneuver because obviously you would want to do the staging operation close to the timing of transplant. And if you're on the waiting list, and the timing of transplant is not very well predictable. And also reduce the waiting time on the list. So you determine the tumor is within a stage that transplant can be used. You do a staging operation and you do the transplant shortly thereafter rather than continue to wait and allow the opportunity for tumors to spread before transplanting. There are some technical considerations here related to the hepatectomy, avoiding the porta. Basically, you don't want to you want to resect the tumor en bloc and not allow it to be exposed to the peritoneum. Spilling tumor cells is associated with a local recurrence. And you may need donor vessels for vascular reconstruction because here you're trying to resect the liver and the portal structures en bloc as one piece. There's some recent data that shows that kind of what you expect, more or less, that this select group of patients actually has a better survival than patients undergoing surgery, even patients undergoing surgery with R0 resection. That is, you don't see tumor, you do a resection, you don't see tumor at the margin, and you have no positive lymph nodes, and still the survival of patients who undergo transplant is better. And this is a recent study, and perhaps liver transplant should be, for a select group of patients, the standard approach, particularly for patients with PSC, because they have underlying liver disease. They typically have multifocal strictures, and they're at risk of additional cancers developing in the future. In the last couple minutes, I'll mention transplant for intrahepatic cholangiocarcinoma. This is again the form of cholangiocarcinoma that presents with a liver tumor mass. Generally, poor prognosis with resection, similar to perihilar, and similarly, early studies evaluating liver transplant for this indication, the survival is poor. There was a small study, not a small study, but an international multi-center study trying to identify patients who incidentally had a cholangiocarcinoma on explant to see what happened. And basically, the idea is that if you have a small tumor, the 5-year survival is actually quite good. But if you have multifocal disease or larger tumors, more than 2 centimeters in size, the outcome isn't as good. The recurrence rate is here in 50 to 60% range, versus the small tumors having less than 20% recurrence rate after transplantation. So perhaps there's, again, a subgroup that would benefit, that you can apply this as a patient selection to figure out which patients benefit from transplantation. This is, there is a single center that has done this protocol, and there is now discussion of doing it as a multi-center study, which is, again, locally advanced and unresectable intrahepatic cholangiocarcinoma, receiving standard of care systemic therapy and looking for disease stability for at least 6 months and no extrahepatic disease. They showed in this subgroup that they can actually get a good outcome with transplantation, with a 5-year survival, 57%. Generally speaking, for transplantation, the limit of acceptability is right there, right around 50 to 60% in terms of utilizing an organ, in terms of 5-year survival. They did have quite a few recurrences. I would say this remains non-standard and in need of further study. So in summary, for the cholangiocarcinoma section, perihilar cholangiocarcinoma, if you have an unresectable tumor, there is a subgroup of patients that does very well with transplantation, we would consider transplant for them. Maybe transplant should be considered for resectable disease. That's an open question increasingly. And then with intrahepatic cholangiocarcinoma, there are promising early results with neoadjuvant therapy followed by transplantation, but again, remains in need of further study. Thanks, everyone. Feel free to unmute and ask questions. I actually didn't check if there's anything in the chat box. There's nothing in the chat box, so happy to answer any questions about this discussion today.
Okay, well, if we don't have questions at this time, we can wrap up the session. Thank you, Dr. Hoteit, for that informative session, and thank you to our guests for joining us this evening. We hope to see you at the next session in the series on Tuesday, November 15th, titled Liver Transplant for Alcohol-Associated Liver Disease, Moving Beyond the 6-Month Rule, which will feature Dr. Kenneth Rothstein, Dr. Jonathan Nahas, and Dr. Ethan Weinberg. Thanks once again for joining us this evening.
Thanks, everyone. Thanks, Margaret.